Ma'am, we're good to go.
Good evening, everyone. I'm pleased to welcome all our audience for sparing the valuable time for this session of ACP India Chapter Case Files, which has been awarded the prestigious John Tucker Evergreen Award. We are honored to have such a distinguished panel of experts today who have very generously agreed to share their expertise with us. But before starting with the sessions, it gives me immense pleasure to extend a very warm welcome to our Governor, ACP India Chapter, Dr. Anuj Maheshwari, sir. Sir is Professor and Head in Medicine, Lucknow. He is Vice President, RSSDI, Secretary General, Indian Society of Hypertension, Regional Faculty of Public Health Foundation of India, National Faculty in RSSDI, API, DIPSI, National Executive Member of the Research Society of Study of Diabetes.
Thank you, Preeti. I think every time you read it, many people must have remembered it. So, not so long to go. And I welcome all the ACP members, all the ACP fellows, those who are joining this program, not only from India, but also from abroad. And I am very, very happy that we are every month completing a new standards in our program. And again, today we are having a very distinguished gastroenterologist of the country, Dr. Ashish Kumar, who is working at the Gangaram Hospital. And he will be presenting a very important case which we used to face in our day-to-day life and day-to-day clinical practice, chronic diarrhea. And we shall be listening the intricacies what he met while managing the chronic diarrhea. Over to Dr. Ashish. Before going to ask him to present the case, would like to introduce him formally. He is MD/DM Gastro, FRCP, FACP, and multiple honors of the various organizations. He is professor and senior consultant, Sir Gangaram Hospital, New Delhi. He is author of more than 150 PubMed index papers among the top 2% of the world scientists, according to Stanford Elsevier, and lead author of the Indian guidelines on HCC. So over to Ashish.
Thank you, ACP, and thank you, our Governor, Dr. Anuj Maheshwari. Thank you, Dr. Preeti, for the introduction. So I'll begin without wasting much of the time. So I'll share my slides. My slides are visible?
Yes. Visible.
So I'll present a case of unexplained chronic diarrhea. And by this case, I want to just teach our dear students, MD students, how to approach a case of chronic diarrhea. So this case was actually presented at our hospital, Sir Gangaram Hospital, as a CPC case. So I'm taking this case because this actually enlightens us how we should approach this case. Okay, so this was a 38-year-old businessman, resident of Haldwani. He presents with a 3-month history of loose stools and weight loss. His present illness is that his loose stools are about 8 to 10 bouts per day, which includes nocturnal stools. It is associated with mild abdominal cramps, but not associated with any passage of blood. The weight loss was significant, which was around 7 kgs over the last 3 months. There was no history of pain, fever, no history of fever, vomiting, joint pains, or oral ulcers. He was evaluated elsewhere and he was advised gluten-free diet and antibiotics. His symptoms persisted despite taking gluten-free diet, although we are not sure whether he was actually compliant to the gluten-free diet or not. He had similar complaints about 3 years ago, along with the complaint of cough and fever. So diarrhea, cough and fever he had 3 years ago, and that time he was evaluated at Haldwani. And in view of Mantoux test positivity, he was started on ATT, which he took for about 12 months. His symptoms did resolve and he did gain weight. He also has history of recurrent folliculitis, for which he had taken off and on oral medications. He also has history of recurrent upper respiratory tract infections during his childhood. So once he came to Gangaram Hospital, his physical examination, physical examination revealed that he had normal temperature, vitals were stable, there was no pallor, edema, icterus, clubbing, or lymphadenopathy. He was poorly nourished and he was BMI of only 17 kg. His systemic examination was mainly unremarkable: CVS, respiratory system, abdomen, nervous system, musculoskeletal system. None of them revealed any clue to any specific diagnosis. These are his investigations: hemoglobin 12, TLC around 12,000, platelets were okay, creatinine was marginally elevated, LFT was okay, total protein was low, albumin was normal, globulin was also slightly low, and INR, his viral markers were negative: HIV, HBs, AG, anti-HCV, absolute eosinophil count was normal. So further investigations which were done at Gangaram Hospital, his stool examination showed only mucus, 1 to 2 pus cells, no RBCs, no ova, cyst, or parasites. His fecal calprotectin, the normal values, which is less than 50, it was normal, it was 43. He had normal serum IgA TTG for celiac disease. CD4 counts were also normal. For his bowel evaluation, we did an upper GI endoscopy, which was normal, but we also took a duodenal biopsy to rule out any malabsorption syndrome. The duodenal biopsy revealed that the villi were normal, and the crypts villus ratio was also normal, and there was no significant increase in any inflammatory cells. There were no parasites seen in the duodenal biopsy. Colonoscopy was also done, which was normal, but ileal had shown nodularity. Hence, ileal biopsy was taken. The ileal biopsy revealed hyperplastic glands. The overlying mucosa was focally ulcerated with occasional regenerative atypia. There was hyperplastic lymphoid follicles, that is Pierce patches, and there was focal cryptitis, but no evidence of dysplasia. So there was some inflammation in the terminal ileum of the patient. For small bowel, we did a CT enterography, which did not reveal any bowel thickening or narrowing. However, there was mild prominence of the ileal folds. And in addition, CT showed hepatosplenomegaly, and there was also thickened lower common bile duct with mildly dilated common bile duct, which is 9 millimeter, and mild central IHBRD, intrahepatic biliary radical dilatation. So while all this evaluation was going on, we started him on general broad spectrum antibiotics and also supportive management. We also gave him good lactose-free diet. But despite all this supportive management of nutrition and antibiotics, he continued to have persistent watery loose stools. And then we did following tests. We did push enteroscopy with jejunal biopsy. We did another blood test and stool biofire GI panel. And these tests actually help to clinch the diagnosis. So I'll just keep this slide here and let you all think what could be the clinical diagnosis. So, so basically, the investigations had revealed normal investigations, slightly low globulin, normal viral markers, and all this. And stools was also normal, serology was okay, and bowel evaluation only some ileal inflammation, and small bowel was also normal. So this was the case which was presented to us, presented to the clinical discussant during our CPC. And let us see how we approach this case. So approach to a case of chronic diarrhea. So whenever we approach to a case, we have to ask certain questions. So is the diarrhea acute or chronic should be the first question. Is the diarrhea functional or organic? Is the diarrhea of small bowel origin or large bowel? Is diarrhea associated with malabsorption? Is it painful or painless? Is diarrhea associated with bleeding? Is there any inflammatory component or is it non-inflammatory? So I will go to all these questions one by one. So in the first step is the diarrhea, acute or chronic. So acute diarrhea is defined as diarrhea which is lasting less than 2 weeks. Persistent diarrhea is that which lasts for 2 to 4 weeks, and chronic diarrhea is which lasts for more than four weeks. So our case was obviously because he had symptoms for about 3 months, so we would label him as having chronic diarrhea. Second step is the diarrhea, functional or organic. So how do we decide whether the diarrhea is functional or organic? We decide by duration. Functional is usually long. It can be as long as 6 months, 1 year, 2 years, and even many years. But organic diarrhea is usually of short duration. There are usually very less constitutional symptoms in functional diarrhea, but organic diarrhea has got marked constitutional symptoms. Weight loss is uncommon in functional diarrhea, but it may be there in organic diarrhea. Appetite is normal in functional, but it is decreased in organic. Then nocturnal diarrhea is a very significant finding, which usually occurs only in organic diarrhea. And increased gastrocolic reflex is a typical of functional diarrhea, but it can occur in organic. And anxiety symptoms are more marked in functional. So in our case, it was mostly organic diarrhea. Coming to the third question, is the diarrhea of small bowel origin or large bowel type? So to differentiate between small bowel and large bowel, we count the number of stools. Usually in the large bowel, there are small frequent loose motions are there. So it is more than 4. But small bowel is usually less than 4. The volume is bulky in small bowel, but it is small in large bowel. The character in small bowel is usually frothy, greasy, and blood is often present in large bowel diarrhea. Mucus is mostly present and pus is present, but it is not present in small bowel diarrhea. So in our case, it was possibly small bowel type. Now, to give you a brief overview of what are large bowel diarrhea and how do we differentiate. So there are 2 types of large bowel diarrhea: functional, which is mostly due to IBS or functional diarrhea, and which is usually defined by Rome 4 criteria. While organic diarrhea is characterized whether the patient is having bloody diarrhea or without blood. So if it is bloody diarrhea, I'm talking about chronic diarrhea. So it could be inflammatory bowel disease, it could be tuberculosis, it could be SRUS, which is called solitary rectal ulcer syndrome, which is associated with often diarrhea, but sometimes with chronic constipation. Then some certain tumors can also produce organic diarrhea with blood. While without blood, it could be due to certain drugs, and it could be microscopic colitis. So this was about large bowel diarrhea. So for large bowel diarrhea, the evaluation is colonoscopy, sigmoidoscopy, or CT or MR. What about small bowel diarrhea? The small bowel diarrhea can be also differentiated based on whether the diarrhea is originating from the mucosa of the small bowel, or from the luminal phase or transport phase. So there are multiple diseases which can cause mucosal diseases like celiac disease, tropical sprue, various kinds of immunodeficiencies, Whipple's disease, Crohn's, tuberculosis. While luminal phase are those which can occur due to maldigestion. So if there's chronic pancreatitis and a decrease in pancreatic enzymes, then it can cause maldigestion. Then there could be bile acid deficiencies, terminal ileal disease. And then there are diseases which can lead to transport difficulty. For example, if there's lymphatic obstruction, lymphangiectasia, then there'll be difficulty in absorption of fat, and then it can lead to diarrhea. So which layer of intestine and how much of intestine is involved? So if it is a diarrhea of a small intestinal mucosa, it could be diffuse, it could be patchy. And among the diffuse involvement, it could be non-ulcerated or ulcerated. And similarly, patchy involvement could be non-ulcerated or ulcerated. So non-ulcerated diffuse involvement means the small intestinal absorptive defects will be there. So these kind of diseases will lead to malabsorption syndrome. While if there are ulcerations, then it can lead to bleeding also, and it could lead to protein loss also. So diffuse ulcerations can lead to protein losing enteropathy and also sometimes bleeding. While those diseases which are patchy and non-ulcerated, so may not have a generalized malabsorption syndrome, and it can have only localized effect. For example, if the defect is only in terminal ileum, there could be difficulty in absorption of vitamin B12. And similarly, patchy ulcerative diseases may again lead to protein loss as well as blood loss. What about large intestinal mucosa? Again, we can have diffuse involvement or patchy involvement. It could be ulcerated, non-ulcerated. So non-ulcerated may have no symptoms, diffuse involvement, or it can present with diarrhea. But diffuse ulcerated will lead to bleeding. So whenever there is ulceration, either in small intestinal mucosa or large intestinal mucosa, there would be bleeding. And for patchy non-ulcerated, there could be no symptoms, and ulcerations will lead to, even for patchy diseases, it can lead to bleeding. The step 4 for evaluation of chronic diarrhea is whether the patient has got features of mucosal malabsorption. So how do we check for malabsorption? So we check for individual component of the whatever food we are eating. So carbohydrate malabsorption would be indicated by generalized weakness. There would be bloating because the carbohydrate, if it is not absorbed, will reach the large intestine where it will be acted upon by intestinal bacteria, which will produce a lot of gas. So it will lead to bloating, flatulence. It could lead to abdominal discomfort and lot of noise. That means borborygmi. How do we assess for fat malabsorption? It will lead to loss of body fat, and it can also present with steatorrhea. So when we ask the patient, he'll say that his stools are oily. And how do we look for protein malabsorption? So there'll be loss of visceral and somatic protein. So he might become cachexic, and his skin fold thickness will be low. So our patient had evidence of malabsorption because his BMI had become low and he was fully malnourished. How do we assess for small bowel diarrhea with malabsorption and without malabsorption? So with malabsorption, there are certain diseases like celiac disease, tropical sprue, and all these can occur. While without malabsorption, it could be bile acid diarrhea, secretory diarrhea, and large volume. So these are some of the examples of small bowel diarrhea with malabsorption or without malabsorption. So next step in our evaluation for chronic diarrhea is whether the chronic diarrhea is associated with inflammatory symptoms or non-inflammatory. So how do we ask for inflammatory symptoms? If it is associated with fever, constitutional symptoms, or joint pains. So in our patient, it was basically non-inflammatory. So non-inflammatory examples are tropical sprue, celiac disease, giardiasis, immunodeficiency, primary lymphangiectasia, bacterial overgrowth. While inflammatory diseases are tuberculosis, Crohn's disease, ulcerative colitis, Whipple's disease, eosinophilic enteritis, and IPSID is a kind of lymphoma, immunoproliferative small intestinal disease. Then the sixth step is the diarrhea associated with abdominal pain. So in our patient, the diarrhea was painless. So what do we get from this? So typical example of painless diarrhea are tropical sprue, celiac disease, giardiasis, immunodeficiency, primary lymphangiectasia. And typical examples of painful diarrhea are tuberculosis, Crohn's disease, IPSID, Whipple's disease, and chronic pancreatitis. And is the diarrhea associated with bleeding, which is very important question. In our patient, there was no blood involved. And if the blood is not there, then usual examples are tropical sprue, celiac, giardiasis, and all this. And if blood is there, then it is typically either inflammatory bowel disease or tuberculosis. These are the examples. So let us compile all the information which we have collected through these questions and apply those to our case. So in our case, it was chronic or recurrent diarrhea. It was of organic nature. It was small bowel origin, and possibly diffuse involvement was there. And it was associated with malabsorption syndrome. It was painless, and there was no associated bleeding, and possibly it was non-inflammatory. In addition, our case also had recurrent infections. There were low globulins and dilated common bile duct. So let us see what are the clues to the diagnosis. The protein in our case was 6.3, albumin was normal 4.3, but globulin were less. So let us analyze this. If the patient has got panproteinemia, that means if protein and albumin both are low, then we would think of protein-losing enteropathy, such as GI loss, burns, large fistula, empyema. But this was not there in our case. If albumin would have been low and normal globulin, then we would have think of decreased synthesis of albumin, like in chronic liver disease, or increased loss of albumin. Again, our albumin was normal in this case. And if it was low in globulin, like in our case, we would think of low synthesis of globulin, which was more likely in this case. So total analyzing the patient, he was 38-year-old male with the recurrent episodes of small bowel diarrhea, with recurrent skin infections, recurrent folliculitis, weight loss, low BMI, HIV was negative, there was anemia. He was negative for anti-T3G, but globulins were low. And also we saw that terminal ileum thickening was there, although duodenal biopsy was normal, and terminal ileal biopsy showed chronic inflammation. And possibly chronic mucosal diffuse disease was there, which was non-inflammatory, non-ulcerative, and no significant luminal disease, no obstruction or so. So can it be celiac disease? Although celiac disease is common, but for this patient, it was negative for TTG. There was no villus abnormality. The response to ATT the response to gluten-free diet was not there, so it is unlikely. Can it be tropical flu, Whipple's disease, IPSID, HIV, and many other diseases? But all these seems to be unlikely. So our main clue was that he had very low globulin levels. So he could have any of these diseases like selective IgA deficiency, common variable immunodeficiency, or secondary due to drugs malignancy, which can lead to low globulin levels. So taking all these into consideration, the clinical discussant made a diagnosis of immunodeficiency. So let me go over the subsequent hospital course. So we started him on antibiotic supportive management. We saw that he did not improve all this. So we did push enteroscopy, another blood test, and stool biofire GI panel. And so the push enteroscopy was although normal, but jejunal biopsy was taken, which showed some blunting of villi with reduced villus and crypt ratio and marked reduction of plasma cells in the lamina propria, which was confirmed. Then stool biofire revealed Giardia as well as isospora. And also in view of low globulin levels and also opportunistic infection, which is like isospora, we sent his all immunoglobulin levels, and which were very low. IgG levels, IgM levels, and IgA levels were very low. However, his CD4 counts were normal. So patient was thus diagnosed a case of common variable immunodeficiency. And then with this diagnosis, he was treated with 500 milligram per kg of IV immunoglobulins for single day infusions, which is repeated every 4 weeks. And the goal is to maintain normal trough levels of IgG levels. And with this, his symptoms subsided and he gained weight and also in follow-up. So this was the diagnosis. It was a challenging case for us. So I'll give briefly about primary antibody deficiencies. There are many diseases which can lead to low immunoglobulin, like selective IgA deficiency, CVID, X-linked disease, and hyper IgM syndrome. Our case had CVID, which is characterized by chronic diarrhea, malabsorption syndrome. Sometimes it leads to small intestinal bacterial overgrowth or GI infection. Common common opportunistic infections are Giardia, cryptosporiosis, CMV, Salmonella, norovirus, and common presentation is celiac-like or IBD-like, and sometimes liver involvement is also there. There are other diseases. The diagnostic criteria for CVID is in any of the following, like increased susceptibility to infections, autoimmune manifestations can be there, granulomatous disease can be there, and unexplained polyclonal proliferation can be there. And we have to exclude secondary hypogammaglobulinemia. Diagnosis is usually after 4th year of life. There's marked low IgG and IgA levels, and sometimes occasionally associated with low IgM levels. No evidence of T cell dysfunction, and also poor antibody response. So if we give him vaccination, the response would be poor, and low switch memory T cells. Clinical manifestations are recurrent sinopulmonary infection, GIT, and skin infections, Some autoimmunity is there, malignancies are common. And GI involvement in CVID is chronic diarrhea, recurrent GIT infections, intestinal lymphangiectasia, immunoproliferative disease. And sometimes autoimmunity is also present, which may be prior to diagnosis of CVID. Commonest is ITP, and there could be other diseases as well. And these patients are prone to neoplasia, and commonest is gastric cancers. Other can be colon, breast, and ovary cancer, and sometimes lymphoma can occur. So this was my case, and thank you for your patient hearing. I will be happy to respond to questions.
Wonderful presentation, Dr. Ashish. I really went back in my post-graduation and undergraduation days with your presentation.
Thank you. Yeah. Actually, when we are into different specialties like cardiology, neurology, we often forget our MD days when we had learned the GI system. So often it gets ignored.
Yes.
Yeah.
In fact, this kind of the cases you find at your tertiary center. How much is the probability of the routine clinical practice we can get this kind of the chronic diarrhea? In routine clinical practice, whenever a chronic diarrhea comes to anyone, the first thing we think about the IBS. Usually, then we think about something, chronic infection might have been there. Then we think about endocrine reason like hyperthyroidism kind of the thing. So, these kind of the probability, how much is possible in routine care?
So this is a rare case. The reason I presented this case because it was presented in a CPC, and the clinical discussion had presented very well how to approach these patients. That is why I presented like if there's a large bowel diarrhea, you will see whether it is functional or like as you rightly mentioned, the most common cause of large bowel diarrhea would be IBS or chronic functional diarrhea. So how do we approach, and by clinic, even before going to investigations, how history should be taken and how examination should be done. So this was the reason I presented this case, because it will be beneficial to the resident who are approaching these kind of patients in their day-to-day practice. Although this case would be very rare in clinical practice. The most common cause would be all the which you mentioned, like functional diarrhea and sometimes malabsorption syndrome, celiac, and all that.
How much common is the malabsorption syndrome in our settings? Usually people don't get diagnosed. Without getting diagnosed, many people stop using the wheat and stop using the gluten-free diet, but start taking the gluten-free diet. But how much reality is there?
So we will suspect malabsorption whenever the chronic diarrhea is associated with weight loss, and whether when he has symptoms of other like carbohydrate and protein malabsorption, he becomes cachexic and his stools become frothy. So usually in our day-to-day practice, we see less than 5% of cases. Usually most common is the functional diarrhea, but even 5% is too much because of our huge population. And whenever the chronic diarrhea is associated with weight loss, then we have to see whether the weight loss is associated with the presence of blood in stool, presence of mucus in stool. That would indicate inflammatory bowel disease. And if none of these are there and weight loss is still there, then we would have to work up for celiac disease, which is very common. Tropical sprue is also there, which is common cause of malabsorption syndrome. So weight loss is a very important clue whenever we are evaluating a patient of chronic diarrhea, which is there
How
about
common,
5 to 10%.
How common we see that chronic infections or worm infestations causing this chronic diarrhea?
Usually when worm infestations also lead to weight loss, but it will not lead to chronic diarrhea. The most common cause manifestations of extensive worm infestation would be anemia, unexplained anemia. So as a physician, we have to rule out worm infestation, do routine stool examination, and at least do deworming, especially in a country like India where worm infestation is very common. But
Right.
when the diarrhea is there, then we have to work up for with weight loss is there, then we have to work up for malabsorption syndrome.
Yeah. Chronic infection other than worm infestation would be having any role?
Yeah, so what we call as chronic infection, which is usually we call in our gastroenterology practice as small intestinal bacterial overgrowth. And one of the manifestations could be tropical sprue also, which is similar to that. So these patients are often there. I mean, about 10 to 15% of patients are there. And even if you're not doing, at least you need to rule out celiac disease, which is very common in especially North India. So once you have ruled out celiac disease, then it is in our practice, we often prescribe long-term antibiotics like rifaximin to these patients, and then chronic, if the patient respond to these rifaximin for 4 to 6 weeks. Usually what people do is they give for only 5 to 10 days. That is not enough. For tropical sprue or for small intestinal overgrowth, we have to give for at least minimum 6 weeks to 3 months. So long-term antibiotics need to be given in these patients, and then we do serious response.
But usually the most common what we get in routine practice, in physician practice, because many of the physicians are attending your program, so they must be interested to know that what we should focus on day-to-day practice most commonly occurring.
So I'll tell you, once a chronic diarrhea present, 2, 3 investigations that like you should always do. One, you should do anti-TTG to rule out celiac disease. The other thing is stool examination to rule out any blood. And then another test is called fecal calprotectin, which many physicians may not encounter, but it is a very good test to detect inflammatory bowel disease. So if there's inflammatory bowel disease in form of especially Crohn's disease, then fecal calprotectin is a simple stool test which can be done. And if the values are high in the range of 100, 200, then you should strongly suspect inflammatory bowel disease. And these patients need to be referred to a gastroenterologist for colonoscopy or endoscopy. Otherwise, if these are normal, then it can be usually managed by physicians themselves without any referral.
Right, right. And how common the diabetes is interfering in this?
Yeah, that's a very good question. Especially long-standing diabetes, patients have motility disorders of the intestine, the number one. And second thing, they also have very increased prevalence of small intestinal bacterial growth. So if the diabetes of long-standing, when we are evaluating for kidney diseases, when we are evaluating for heart disease, and if the patient has got this time of presentation chronic diarrhea, then one thing, apart from the metformin and other drugs which you'll evaluate, you also need to see their intestinal motility. And sometimes it helps to give certain antibiotics because these patients have increased propensity of small intestinal overgrowth. So you can try 4 to 6 weeks of certain oral antibiotics. And we prefer generally giving gut-specific antibiotics rather than those are absorbed. So nowadays for that, rifaximin is a good choice. You can give for 4 to 6 weeks in these diabetic patients who often have chronic diarrhea due to small intestinal bacterial overgrowth.
And many of the patients now we get hyperthyroidism or thyroiditis also a chronic diarrhea, especially the young girls that are coming with the weight loss and having the chronic diarrhea, and they are detected with the hyperthyroidism many of the time.
Yeah, the diarrhea which is there in hyperthyroidism is mainly secretory type. And with the hyperthyroidism, because of thyroid toxicosis, there would be weight loss also. So it may mimic malabsorption syndrome. But one thing which can differentiate clinically, if you, I mean, the resident may be asked this question. If the patient is fasting for some reason, for example, some fast, Monday fast or any festival fasting or Navratri fasting, if the diarrhea gets better, then it is not due to malabsorption, it would be secretory diarrhea. So this is one clinical clue. And then obviously the basic workup of any chronic diarrhea would be thyroid profile test, and it will give the clue immediately. TSH would be very low in those patients.
Very good. Very nice information we have received, and in fact, very good case you presented, which is not very common to us, but definitely it was quite interesting to know about. My many other colleagues are also joined here, would be happy if anybody is having any query and would like to come up with that. Dr. Amit, Dr. Ajay Tiwari, Preeti, if you are having some query, you are again at a tertiary center at AIIMS Bathinda, you may be getting these kinds of the difficult cases there, or rare cases, in fact, not difficult. Dr. Ajay Kumar is also connected. So anybody is having anything to comment or anything to ask Dr. Ashish, you are welcome.
Thank you, sir. It is an excellent case presentation by Dr. Ashish, sir. And my video is off, sir, because of poor network. Sir, I would like to ask, as you have rightly pointed, that when you are giving rifaximin and you are recommended that it can be given for a longer term, maybe 4 to 6 weeks, and in some cases even up to 6 months. So do we need anything to monitor when a patient is on long-term antibiotic? And many times, sir, we do combine prebiotics and probiotics also with rifaximin. So how do you see that interactions are happening?
So rifaximin is a non-absorbable antibiotic. So it is all excreted in the stool. We still do not know what is the mechanism of action of rifaximin, but it is said that it actually leads, it normalizes the intestinal flora. And usually some of the patients on rifaximin may develop bloating or some abdominal discomfort. So tolerance is a problem, but it's only in less than 5% cases. Usual adult dose should be 550 milligram BD. What I've seen in clinical practice that many people prescribe in low doses. So that is not enough. If we want to achieve its full benefit, it should be 550 milligram BD. And we actually do not need to monitor anything, because recently even studies have come where rifaximin was given for 18 months in patients with alcoholic liver disease, where there's significant amount of endotoxemia and liver damage. So long-term rifaximin can be given. However, 4 to 6 weeks is generally enough for these patients of chronic diarrhea.
Thank you, sir. Thank you.
Yeah, okay. Dr. Anuj, your audio is off, I think.
Thank you, Ashish. Wonderfully you presented, and we enjoyed your presentation and got new information. Also, I believe our listeners and attendees must have got new information in their basket. So hopefully we'll be having a very good similar case and better case in next time also. But another half hour is dedicated to another important talk for early career physicians. And this time we are going to talk about the ethical issue. You remember for last few days have been very much stressful for all the medical fraternity, when many different kinds of the new restrictions and new kinds of the rules have been given us to follow. Later on, they have been withdrawn also. But this is the right time. We should go into the details of that, and we should also introspect where are we really lacking because of what these kinds of the things happen with us again and again. So for that purpose, we have also invited Dr. Ajay Kumar. Anybody would like to give the small introduction of the Dr. Ajay Kumar? There any slide? Amit, do we have any slide?
Yes, sir. We do have, sir.
Yes. Dr. Ajay Kumar is a MBBS MD in the forensic medicine toxicology, additional professor and associate dean forensic medicine and toxicology at AIIMS Bathinda. Dr. Ajay Kumar is presently working as additional professor in the Department of Forensic Medicine Bathinda. He is having more than 21 years of the teaching experience and a lot of publications, lot of theses he has guided, and he has also published 2 books on the forensic medicine and toxicology. Awards are also he has got, and he has also participated in national and international conferences. With this introduction, would like to have the comments of Dr. Ajay Kumar, what I really just expressed my feelings, or what you can say my views of the last few days, what has happened, and then I would like to have your deliberation, what you want to say, then we will be asking our question. Over to Dr. Ajay Kumar.
Thank you, organizers, ACP India chapter. Thank you, Dr. Anuj Maheshwari. Thank you, Dr. Preeti, for inviting me for a talk. First of all, I would like to say that the regulations which they just framed, they actually put it mandatory for all physicians to actually
your voice is breaking. Dr.
prescribe the
Ajay, your
generic,
voice is breaking.
actually guaranteeing.
Yes.
Hello, am I audible?
Yeah, now better, we can.
Right. So basically, without seeing the consequences of those mandatory acts, they have just implemented and tried to implement those newer guidelines in the NMC. Whereas now, due to some pressure from the pharmaceutical industry as well as from IMA and all doctor fraternity, those NMC guidelines have now been withdrawn, and the status quo of Medical Council of India Ethics, Product Etiquettes and Ethics Regulations 2002 are now again in force. So they have just prescribed those ethical guidelines. These are not yet mandatory. So they will work up something and then they will come with new guidelines.
What is ethics? Many a times we call that we should do the ethical practice, ethical medicine. Actually, we don't understand what do you mean by ethics. Ethics, if it is a kind of the honesty and truthfulness, then everybody should follow that. Why only doctors? And doctors should also follow that truthfulness and honesty. So why do we always given that
so let
ethical
me go
practice,
to my
ethical
presentation
medicine?
and
Yes.
you will be
Yes, please, sir. Now you respond.
okay. So let's start our presentation and you will be
Yes,
a bit clear about what
Yes,
are ethics and what is mandatory, or whether these are mandatory or not. So
Yes,
whether
right.
they infringe on certain laws or not. So let me share my screen.
Sure.
Presentation is visible. Is the presentation visible?
So it's visible.
Okay, let's start with my present topic of ethics in clinical practice. First of all, greetings from AIMS Batida. I'm Dr. Ajay Kumar, Additional Professor in Department of Forensic Medicine and Toxicology. You have already been briefed about my brief biodata. So let's go to the presentation straight away. In the overview, I will be telling about the objectives of certain ethics, definition, components of ethics, then about certain principles and ethics and law. How do they intermingle and interrelate? So let's go to the objectives of ethics. In these objectives, we try to understand the dynamics between ethics and the law. What are ethics and what are laws? And how do we implement contemporary ethical principles by examining the difference between ideas and duties? Okay. Then we will also see about certain principles of ethics and certain principles which guide those ethics. And of course, the common terms of ethics. So let's few more understandings of ethics may differ among different cultures. Why this knowledge is important, and importance of ethics in modern medicine in today's diverse healthcare environment. Different people may have different ethics, different doctors may have different ethics, and how to utilize ethical principles as guidelines for decision making while caring for our patients. So this important concept of ethics in which the ethics are the moral principles which guide the members of a medical profession in dealing with each other, dealing with their patients, and dealing with the state or law enforcement agencies. So it is actually the study of doctor-patient relationship, including complex issues such as honesty, competency, integrity, respect for the patient, along with certain specific issues such as telling the truth, be honest, informed consent, end of life care, All these things, they come under ethical principles or in cases of ethics. So what actually are the components of medical ethics? These are the 4 components of medical ethics. That is, one is physician-patient relationship. How do physicians, they deal with their patients, whether they are honest, whether they take informed consent, whether they prefer to act in beneficence or in non-maleficence to the patient, and so on and so forth. Similarly, ethics also tells about dealing with physicians to physicians relationship. The relationship of physician to the system of healthcare also is involved in ethics. And lastly, relationship of the physician to the society. These all are the components of medical ethics, wherein the physician has to, as per the Indian Medical Council Professional Conduct, Etiquettes and Ethics Regulations 2002, has to follow all these things. They have already enumerated a lot of do's and don'ts, but are required from physicians at physician-patient relationship, physician-physician relationship, and relationship with the system of healthcare and with the state. So let's see what are ethical principles. So these ethics are guided by certain principles of autonomy, principle of non-maleficence, principle of beneficence, principle of veracity, principle of confidentiality or fidelity, and lastly the principle of social justice or justice. So we are going to deal with all of these one by one. So let me first take the principle of autonomy, where people have the right to control what happens to their body. It is their body and they have the right to decide what should be done to their body, whether it is right or wrong, but you have to act according to the patients. This principle simply means that an informed, competent adult patient can refuse or accept treatments, drugs, various choices offered by you for treatments, for drugs, for surgeries, according to their wishes. Now, people have the right to control what happens to their bodies because they are free and rational. These decisions must be respected by everyone, even if those decisions aren't in the best interest of the patient. So the autonomy of the patient is of paramount importance. If the doctor thinks that he is more knowledgeable and he has extra knowledge or than the patient, then he can tell whether all these things, he can give or impart knowledge to the patient and let the patient decide or choose what is actually best for him. So this principle of autonomy respects patients' right to make their own decisions. You don't have to force your decisions or physician's decision onto the patient. And similarly, the doctor is obliged to teach people about how to make their informed choices. These all comes under the patient autonomy. And in these, the doctor has to support people in their individual choices. And please do not force or curse people to do things, or do not put undue, unnecessary emphasis on certain kinds of treatment than others. And lastly, informed consent is an important outcome of this principle. So in patient autonomy, informed consent is one of the pillars of autonomy of the patient. Let the patient decide what is best for him after telling all the things about treatment, drugs, effects, side effects, contraindications, cost, benefit, adverse effects, alternative treatment. So all of these things must be told, and then only informed consent has to be taken, in which the patient will decide whether he wants to go for certain kind of treatment or not. So this was more or less about principle of autonomy. Then we have the principle of beneficence, where all healthcare providers must strive to improve their patient's health and to do most good to the patient in every situation. So whatever act you do, you have to keep in mind the benefit of those acts for the patient. So it is, in other words, doing good for the patient. And you have to strive for net benefits for the patient. Let's say, for example, if we take treatment where it has effects as well as side effects, So we have to net balance whether the effects are more or side effects are more. If the effects are more, then you go ahead and employ that treatment, otherwise not. So all healthcare providers must strive to improve their patient's health. But keep in mind that what is good for one patient may not be good for another. So each situation should be considered individually. Every patient is a unique patient, and one treatment may not suit the other patient. So you have to keep an informed decision about what is benefit for that patient. Patient's welfare is the first consideration. Our actions or the physician's actions must aim to benefit people, be it in health, welfare, comfort, well-being, or to improve a person's potential or improve quality of life. This benefit should be defined by the person themselves. It is not what we think what is important. Okay, so the benefit has to be defined in terms of the patient's satisfaction, whether he is satisfied with that benefit, with that intended benefit or not. If he refuses to take that intended benefit, then the principle of beneficence will not apply. And you have to act on behalf of vulnerable people to protect their rights, because if you are acting for the beneficence of others, you have to have certain skills and knowledge so as to comply with all the needs of the patient. For example, an unconscious patient needs much more skill and care than a conscious patient. So you have to put in the principle of beneficence for that patient only. If you omit to do those beneficial acts, then obviously it will be an act of omission. And if any damage or harm occurs, then you will be responsible. Similarly, in principle of beneficence, you have to prevent harm. You have to apply all your skill and knowledge to prevent that harm, intended or potential harm to the patient because of his vulnerable either age group or due to vulnerable condition. And you have to create a self and support environment for beneficence. And lastly is to help people in crisis. This is again a principle of beneficence. Now we have third principle, which is the principle of non-maleficence, which is it requires that a procedure does not harm the patient involved and others in the society. So it is not doing any harm to the patient. Thus, this principle says that you should not harm the patient, or you should not act so that the patient gets harmed. It concerns about first, you should not do any harm, and you have to preserve the sanctity of life. But in this principle of non-maleficence, you have to be aware of the doctrine of double effect, where a treatment intended for good unintentionally causes harm. For example, in cases of chronic carcinomas, where there is a lot of pain, you give morphine to alleviate the pain, but simultaneously it is causing respiratory depression and causing the person to die, I think. So that will be, you have intended that the pain should be alleviated, but simultaneously you are doing harm to the patient. So this double effect should also be considered in this principle of non-maleficence. So broadly, in principle of non-maleficence, you do not inflict injury or harm to the patient, or do not aggravate pain or sufferings of the patients. Please do not incapacitate the patient, or do not cause any offense under any law. Do not deprive the people, and do not kill. So these are principles of non-maleficence. Then we have the last principle, which is the principle of natural justice, where complex ethical principles with meanings that range from fair treatment of individuals to the equitable allocation of the resources of the state. We can think about oxygen concentrators at the time of COVID, where oxygen concentrators were quite a few, but patients were a lot. So naturally, we had to follow principle of natural justice, be it like giving oxygen concentrators on a first come first served basis. So that was just a principle of natural justice. You don't regard to the caste, creed, or not favor any individual or group over others. This is what is known as principle of natural justice, and you have to treat people fairly and adequately. Acting in a non-discriminatory or non-prejudicial way is the principle of natural justice, and you have to respect for people's rights. And simultaneously, in following the principle of justice, you have to respect for the law. So these were the 4 principles of medical ethics, whereas we have 4 rules also, 4 ethical rules, which are veracity, privacy, confidentiality, and fidelity. So besides 4 principles, we have 4 ethical rules. First is the rule of veracity, where you should tell the truth to the patient. You should not exaggerate the condition of the patient, or when you go and take the informed consent, you should not exaggerate the illness to the patient. You have to tell the truth. Whatever is the truth, you have to bring out the truth. So there is a common saying that you tell the truth or someone will let it for you. Okay. And then you have obligation to full and honest disclosure. These are the, again, ingredients of informed consent. You have to be truthful and you have to have full and honest disclosure. Then we have the rule of confidentiality, where everything what transpires between the patient and the doctor has to be kept confidential, and it has to be based on loyalty and trust. Maintain all the confidentiality of all personal, medical, and treatment information. These comes under the rules of ethics. Of course, there are certain exceptions where information can be revealed with consent or for the benefit of larger society. So this rule of confidentiality also follows that disclosure should not be beyond what is required. So only that points are to be disclosed which are needed to be disclosed, otherwise they have to be kept confidential. Then we have the rule of privacy, where it is again based on loyalty and trust, where privacy is to be maintained for all patients, be it young or old or female or male. And then the last rule of fidelity is loyalty, maintaining the duty to care for all, no matter who they are or what they may have done. So in this rule of fidelity, you should not be prejudiced to certain sections of the society or to certain criminals or offenders that they have done such a wrong, then you are not going to treat them or like those conditions. So you have to be faithful and loyal towards your profession. Now, ethics also contains now 2 broad philosophical theories also, which are consequentialism, taking the consequences of our actions into considerations, and deontology, basing our actions on a set of principles or duties. So let me first touch upon consequentialism, where actions are right or wrong according to the balance of their good or bad consequences. So you have to first look at the consequences of what you are doing. If they are good, then it is a acceptable or ethical issue, ethical justifiable act. If the consequences are bad, then of course it is not ethical. The right act is the one which produces the best overall result. So in consequentialism, there is another entity which is known as utilitarianism, where what actions has the greatest utility, use, or benefit or positive outcome is a type of consequentialism. Most prominent consequence-based theory, and it is based on the principle of utility, whether the actions which you are doing are of use to the patient or not. Actions ought to produce the maximal balance of positive values, that is happiness, versus disvalues, for example, the harm. Now, the another theory which is known as deontology, it is duty or principle-based theory, where the NMC code of conduct is a product of deontological ethics, where it guides actions based on a set of principles and or duties. So they have the NMC code of conduct has enumerated certain guidelines for the doctors to follow in dealing with the state, dealing with the patients, dealing with doctors to doctor relationship, how do they have to deal with it, Okay, so this was more or less about deontology. Now, coming on to what is an ethical issue. Now, the question is, how do you judge whether it is an ethical issue or not? When you have to judge what is right or wrong, that contains an ethical issue. You have between choosing treatments becomes an ethical issue. If there is only one treatment for a condition, then you have to take that treatment. Otherwise, when you have choices among different kinds of treatments, then only it will be a kind of ethical issue where all the rest of the considerations, like what are the effects, side effects, contraindications, cost, benefit, they have to be weighted for all the different kinds of treatments, and then you have to choose one treatment. Deciding whether to do something or do nothing again contains an ethical issue. Should I or shouldn't I? So, weighing upon the potential impact of your decisions or actions again contains an ethical issue. So, you have to be very specific. You have to apply all your brains in making the right choice. And the right choice can be made based on your knowledge, your experience, experience of others, kind of patient, kind of treatments available, and so on and so forth. So now, what is a ethical dilemma where there is conflicting values, no clear consensus as to what is the right thing to do? So that involves a conflict between moral obligations that are difficult to reconcile and require moral reasoning. Suppose we have two choices. Now, which choice would you take that will both are effective and both are having certain advantages and certain disadvantages? How will you choose the one? So that will involve ethical dilemma, which one to choose, which one not to choose. So in modern healthcare and research, again, we have certain conflicts where there appears to be no clear consensus as to what are the right things to do. For some people or for some practitioners, accepting one particular kind of treatment may be beneficial, whereas other group of practitioners may think that some other kind of treatment is more beneficial to the patient. So these are ethical issues in modern healthcare. Let us take an example of ethical issues in modern healthcare. Should a parent have the right to refuse immunization for his or her child? Because as per medical legal guidelines, it is the guardian or the parent who can give the consent for immunization. Certain immunizations in which the state has given the consent to administer those immunizations, but for others, it is the parent or the guardian who will give the consent for his or her child to get immunized. So, does public safety precedes an individual's right? Suppose somebody refuses oral polio vaccine. So it is the individual's choice. But again, now this public safety supersedes an individual's right, whether it is right thing to do or not. It is again an ethical issue. So sometimes what happens is those principles of autonomy, beneficence, non-maleficence, and natural justice, they interclash with each other. So you have to weigh whether the autonomy will carry more weightage than a principle of non-maleficence or beneficence. For example, let me take conflict between autonomy and beneficence or non-maleficence, where sometimes Jehovah patients may refuse blood transfusions based on their religious and cultural views. Now, it is the autonomy of the patient that he is refusing blood transfusion because his culture does not provide to have that blood transfusion. Whereas the physician will say, no, you have to get that blood transfusion, otherwise the hemoglobin is very low and you may or may not survive, or there will be adverse effects of those treatments. So now, what will you do? whether you will respect the autonomy of the patient, or whether you will do beneficence for the patient. So these are kind of some crossways between those principles which should be taken into account, though we don't have any clear-cut instructions or guidelines which one to follow. So it depends on patient to patient and physician to physician also. Some physicians, they will prefer to transfuse blood. Some prefer to respect the autonomy of the patient. So similarly, some other questions: should children with serious birth defects be kept alive? This is again an ethical issue, ethical question, which you all have to ponder upon. Should a woman be allowed an abortion for any reason or not? Or should there be any guidelines? Or there should be any more modifications to the current MTP Act? Should terrorists be tortured to gain information, possibly saving hundreds of lives? So these are some of the questions which you can think of, which have the ethical issues. So there are certain ethical issues in research also, whether to continue with stem cell research or research cloning or genome projects results or fertility research. What will be the outcome? What will be the outcome as regards to the patient, or as regards to the new product or new baby? Some more questions: should organs for transplantation be able to be purchased? Now this contains a lot of ethical issues, whether it has to be purchased or not. There are a few more ethical questions which are not yet answered, but we are searching for those. Now, these are my few references. Thank you. Over to you, Dr. Anuj Maheshwari.
Thank you. Thank you, Dr. Ajay Kumar, for a great presentation. Again, it was quite enlightening. Before I come to my questions, I would be inviting all my colleagues, those who are here, if they are having some question in their mind, they can come up. So, Amit, if you are having any question in your mind, or Ashish, if you are having any question in your mind, please come out.
So can I ask my question?
Yes.
Please.
So are these ethical principles only valid for us, like modern medicine practitioners, or are they valid for
Exactly
Ayurvedic?
same
And
question was coming in my mind, but
for
I was
example, I'll give
thinking.
you, like we give the patient autonomy to choose the treatment, and we explain to him the benefits and harms of the treatment. For example, some patient comes with cancer and we tell him we have to give radiotherapy, and he will be benefited like 60%, and there would be chance that he'll have side effects and not respond by 40%. Other Ayurvedic practitioners give big advertisement that we have got 100% cure for cancer, hepatitis, and all kind of disease. We can take away dialysis and all that. The patient is a poor patient. He is not knowledgeable. He doesn't know how to choose treatment. So he would go to that person. So where does the ethic lie?
Basically, these all ethics, they are contained in the NMC code of professional etiquettes, ethics, and conduct for the physicians. So we are all registered under the MCI or NMC. So those people, those who are practicing Ayurveda or homeopathy or other disciplines of medicine, they are not governed by these ethical principles, though they may have certain ethical principles of their own. But what we follow, it is not like that they are going to follow our principles also. So they will claim to all that they can cure cancer and whatnot. But it is not for us to say untruthfulness to the patient that we can cure 100%. So we can claim 50%, 60%, or whatever the type of cancer is. So we have to be honest. That is one of the rules, that you have to be very honest to the patient.
Yeah, so it's an ethical question only. With our honesty, the patient actually is misguided by other people.
Yes.
And the one more question I want to ask, for example, during the COVID era, like you also mentioned about vaccination. So there were
Right.
people who were denying COVID vaccinations, although as principles of autonomy, they are right to do so. But those
Yes.
people were at risk of spreading the disease to other COVID and all
Yes.
that at the peak of COVID. So again, what would be ethic? What would ethics say? Should we should have vaccinated them, or should we have allowed them to roam about freely with the risk of spreading COVID?
No, basically, I have already told that these principles, they always cross intersect each other. Whether the rights given by the rights of the individual given by the state is more important than the individual rights of the patient. So if they choose to have not been vaccinated, it is up to their wish. But still, the government has made it mandatory at some point of time to get all the persons vaccinated. So it was part on the government to provide the consent for getting the vaccination of people. But still, there were many people who choose not to get vaccinated. So it was their right. They exercise their autonomy. We can't force them. So basically, these are all ethics. They are not actually the laws, but they are just the guiding principles. Whether the physician, if you are not going to follow ethics, some physicians, they don't follow ethics, but they are not punished unless until the patient is harmed in some way or other. So actually, the law provides that all the 4 Ds of negligence, they have to be fulfilled to get physician punished. Otherwise, it is these moral principles, they are not mandatory. They are just the guiding principles which we have to follow as good practitioners.
They are moral principles, they are not binding, as you
Yes.
say, but if somebody is not following law, is always ready to punish. Many a times
No,
it
basically,
has been seen that people, those who are not following the ethical practice, they have been sentenced in the court of law, and because of what they suffered a lot, many people had done suicide also. So, court of law understand these ethical principles as rules or regulations for us. And in fact, NMC, what has been released, which has later on taken back, was also initially given a shadow of ethics, and later on they made it regulation in the
yes.
subsequent part. So these kinds of the dual standards are being faced by our community. How can we really overcome these kinds of the dual standards?
No, basically, until the regulations are framed and laws are put in place, these are still the moral values and principles. These are the moral principles which guide the member of a profession. So unless they become part of regulation or part of law, then only they can be punished. Otherwise, it was going on for years only.
So I want to ask,
Yes. Preeti.
should the physicians do whatever the patients say in the name of autonomy?
Basically, you have to again weigh what the person is saying. What are the benefits of allowing him and what are the benefits of not allowing him? You can't agree to each and every demand of the patient in the name of autonomy. You have to again apply your mind and decide whether the treatment demanded or treatment being refused by the patient is actually beneficial or not. Somehow this
So we should
grab of
hold him tight and
paternalism
put
where the
the
doctor
injection
they
vaccine.
decide for the patient.
So, Dr. Ajay, should we hold him tight and put the
Pardon?
vaccination by force?
No, basically we have to just inform the patient that you are going to select such treatment or you are not going to select such and such treatment. These are.
I think you're breaking, not really coming first.
Voice is not there.
I think network connection is problem. So another ethical question which we were about to face was with the NMC guidelines was about writing generic medicines. So
Dr.
was the
Ajay,
question.
you are muted now.
Yeah.
Kindly unmute. Yes.
Yes. So what I was saying that you have to again give all the information to the patient and let him decide whether what he accepts.
Sir, I
Dr.
would like
Ashish
to.
has asked another question. Would you like to comment on that?
I couldn't hear. Actually, I was a bit logged out
Can
from
repeat,
the.
Ashish.
So I
Kindly
was
repeat.
asking, like recent NMC guidelines had suggested the prescription of generic medicines
Right.
and not the branded ones. So how to ethics, for example, the patient insists, tell me the brand. So what would have been the ethical implication and the legal implication in that situation? Although these guidelines have been withdrawn, but the patients may often ask their doctors, okay, tell me if you have written generic, but which medicine should I buy? So if we tell
Yes,
Sun Pharma,
you can record whatever you are saying and whatever the patient is saying. If he is saying that please a few names about it or branded medicines that I want to purchase. So you can enlist 1, 2, or 3 brands, either generic or brand names. So there is no legal issue in that. You have given multiple options to the patient. Let the patient decide which one to buy. We can't force to buy a generic only.
If I'm writing about 5-6 medicine in a prescription and every medicine I'm giving 5-6 options, then again it would be a difficult choice for the patient and difficult to understand even for the buyer or even seller. So
now basically every patient won't demand that you write 2, 3, 4 or 5 medicines. If certain patients they ask for it, then we have the every right and we have the every responsibility to inform the patient.
Amit, you wanted to say?
Yes, sir. Sir, I wanted to ask one thing. When there is a conflict between the ethic and as well as the regulatory guidance, and it often puts physicians in a sense of confusion that what to follow and what not to follow, as rightly pointed out by this generic one. This was actually a conflict between the ethic as well as the regulations. So what I would like to highlight, request you, can you highlight few points which we can take away as a basic principle that these must be done in a busy OPD practice, so that all of us follow these 1, 2, 3, 4, 5 should be done and these should not be done.
So regarding regarding these regulations?
No, sir, it is not regarding, in general, I am asking that
Okay.
what are the 5 good practices which we must
Ethical
follow
principle, because regulations are always binding.
Yes.
So you can't go away from the regulation.
5 things, any top 5 things which safeguards our prescription and also help the patient, and which is something which should not be done, whether there is a guideline or not, or whether there is a ethical recommendation or not. So do's and don'ts, absolute do's and absolute don'ts.
Absolutely. Let me start with absolute do's. First, you have to give an informed decision or an informed choice to the patient, right? Just like we take informed consent, if we tell everything to the patient, then you have to document it also. First is giving information, full information, nothing to be concealed. Then you have to document what you are telling to the patient. Number 2 point. Number 3 point is you offer him all the choices and let him decide. That is principle of autonomy, right? Let him decide what is best for him. And I think these much will suffice. Beneficence, non-maleficence, these are secondary things which you will obviously take care of. So, and principle of natural justice, we don't usually encounter in clinical practice, though in government hospitals, yes, we sometimes encounter in government hospitals also, like scarcity of beds, whom to admit, whom to not. That is principle of natural justice. So 3-4 points you have to keep in mind. And absolute don'ts, you don't coerce the patient to follow certain things. You don't threaten the patient, or you don't exaggerate what the disease is about. You tell him all the pros and cons of the disease. I think that will suffice.
I think we have already accelerated our time. So should we end the program, or if there is any question, one or more question can be allowed? Otherwise, Preeti, we should conclude this program. You are muted, please.
Sir, I would like to invite Dr. Amit Gupta, sir, Advisory Council member, ACP India chapter, to say a few words and propose vote of thanks.
Thank you, Dr. Preeti. Thank you, Anuj sir. And it was a wonderful two interesting discussions happened today. And one was on chronic diarrhea. I'm sure all the viewers must have benefited with this conversation today. And ethics is always you can say it is a question which has been coming to everyone's mind. And recently it was in the news for multiple reasons. With Dr. Ajay Kumar's talk, I am sure we must have gained some insight into the ethics as well as the regulation. So it will certainly help us in improving our clinical practice as well as in taking the best clinical decisions for our patients. So I'm thankful to Dr. Ashish as well as Dr. Ajay for accepting the invitation on behalf of ACP India chapter. I will hand it back to Dr. Preeti to make the final closing remarks and close the session.
Thank you, sir. Both the sessions were very informative and they were very useful for a routine clinical practice, and looking forward for more sessions, more such informative sessions in near future. So thank you, everyone. Thank you, sir.
Thank you, sir. Thank you.
Okay, bye-bye.
Bye-bye. Thank you.